Okay, good afternoon. Today we will look at health systems, what a health system is, and some definitions of a health system. What is our national health system? Also look at how these have evolved over time, development or evolution of health systems, and why study health system, why we should study health system. What are the functions of a health system, then what determines a health system, and what are the basic components of a health system, and we will learn a classification of health systems. And then we will look at some countries and see how those fit in, and we will get a better understanding of health system and why we should study health system. So what do you understand by the word system? Where do you come across the word system? Yeah, in the body, that is a classic example. We have various systems in the body. Respiratory system, cardiovascular system, nervous system, and so on. So, what does a system do? Those different systems have different functions. Right. So, what is important in a system? So, the system makes a complete listing. In that there are subsystems. So, if you take a human body as a system, within that you have different systems, what you mentioned. So, for the human body to function, these systems all should work. So systems are things that work harmoniously with others, interact and perform various functions. So therefore system can be defined as a set of interrelated and interdependent parts designed to achieve a set of goals. So you want to achieve something, but those are interrelated, a set of interrelated and interdependent parts. Now, if you take the respiratory system, there are the lungs are there, the tubules are there, the trachea is there, the nose is there, so all are related to one another. Right. So you can't have the lungs, the bronchioles, bronchi, the trachea, larynx, the nose, and also you can't have the kidney also or the ureter as part of the system, because that is not interrelated in that system. So it is interrelated and interdependent parts designed to achieve set of goals. It make there's some functions and achieve some goals. Right. So that's how you define a system. Then when you come to the word health system, again health system is a set of interrelated, interdependent. Now what are the, in the health system, what are the components that you will see which are interdependent, interrelated? What are the two broad areas of the whole, to take the whole Sri Lankan health system, broadly we can divide into, right, one. Terms of services, the goal is to provide health services. So you have the hospital system, which provides patient care. Then we have the preventive health services, which provide the preventive health services. Each depends on interdependent and interrelated, both has to work harmoniously. So a health system is comprises of all. You can put everything. Not only even the ministry that do the administration, right? All organizations, institutions and resources devoted to producing actions whose primary intent is to improve health. Why do we have a health system? To improve health. Therefore, anything that helps you to improve health can be organizations. There are hospitals, there are clinics, there are the ministry, the district offices, all are organizations or institutions, or even resources. You have various other resources, the facilities. Producing actions, all do certain things, whose primary intent is to improve health of the people. So if you take as an example, we took the national health system. We can broadly divide into various components. We have the public system, we have the public, that is the government run system, and also we have the private system, the private hospitals and the GPs, all that is the private system. In addition, we have the traditional system, that is also providing healthcare. Everybody is providing healthcare to the people, and the other informal sectors. So everything is part of the national health system. So there are 4 essential functions of a health system, have been defined as, there are 4 basic functions. What are the basic functions of a health system? Any health system you take, one is, the most important thing is providing services. That is one important function, providing services. People who get sick, they are provided with outpatient services, inpatient services, laboratory services, so various services. Then other one is, the private sector is more also interested in generating resources, resource generation. Financing, it's another function of a health system cannot function without financing. And the other 4th function is the stewardship, or the governance or stewardship. New leadership to run the district, the ministry, part of the health system, it provides the stewardship with the leadership, manages the services. Right. So those are any health system, so those are the 4 basic functions of any health system. Service provision, resource generation, financing and stewardship. Right. There are so many others, these are the 4 basic functions of a health system. So the structure and functions of a country's Ministry of Health, having resources, management, organization, economic support and service delivery as its main component. So the Ministry of Health is providing all this, is a part of the system. So the national health system include the public system, the private system, traditional system, then there's this informal sector, NGOs and various other, they are also providing various types of services. So the 4 essential functions, one we said service provision, provide services, that is mainly. Then resource generation, they have to generate resources to run the services. Other one, third is financing, and fourthly the governance, stewardship or leadership, providing the leadership for that. So those are the 4 essential functions of any health system. So you can look at any health system, even in other countries, based on these 4 areas of functions. Key to effective health systems. It's very important to a health system to run. You need to have motivated staff. You need to have equipment. You need to have information. You need to have finances. And you need to have adequate drugs for improving access, coverage, delivery of health services. So, key to effective. Now, what is the most important of these? In a health system, there are so many components. Right? It's like a machine or say even a clock. There are wheels. Right? All have to work harmoniously. The system to work, all have to work individually. It has this thing, but it has to work with the other parts. If one part is not working, the system will not work. So that is the story. So for the question I asked, which one is most difficult? So the body systems, they had a meeting. They were discussing who is the greatest, who is the most important, the human body. So they had a meeting and were discussing. So various people started, the brain started saying, I am the most important person. So I should be appointed the leader because I give commands. Everybody work when I give the commands. Then the heart said, how are you going to work? If I don't pump the blood, you can't work. So like that, various people telling me then the famous when said, I'm the most important person. I said, shut up, you. You have a reason to forget your so you stop work. First day, okay, very. Second day, by the third day, these people, nobody. So, that in the system, everything is very important. Everybody is very important. So, development of a health system. So, when we are developing a system, you need to look at the organization. Changes in character with time, how the organization should evolve. In terms of that, we need to increase the resource expansion, and then the people will be more and more using the services, so increased in utilization. Then that causes increase in expenditure and financing pattern of healthcare. Then you need to look at cost control strategies and increasing systems efficiency. That is a huge challenge that we are facing. The government spending very little money, 1.6% of GDP for healthcare. It is hardly educated but we are anyway somehow delivering the things. So so we need to increase this thing. But on the other hand, if we cannot now, we have this morning I was listening to the Minister of Economic Reforms talking about, he was asked this question, and why spending this amount of money for health sector. So the loans, we have to pay the loans, and then to take 100,000 rupees, about 98,000 goes to pay the loans. So we have to run the 2%. Then there are other priorities are there. Education also needs money. We have to invest more on education, on health. So it's a huge challenge. So under those circumstances, what can we do? What we can do is to use the available amount more efficiently. So we can cut down some of the unnecessary costs and make the system. That's why we have achieved a lot of things. With little money, we have achieved good indicators. Because of that efficiency, with little money, we are underpaying the staff and all that. So they are delivering the services. So increase the utilization, increasing expenditure financing, in cost control strategies, increase the system's efficiency. So that's another way of doing the financing. Then we need to look at the things are improving day by day, new technologies coming in, and we have to invest on those technological advances, the demand and the application, and the emphasis on prevention. Then the people are more knowledgeable now, they want quality services, so quality assurance. Then about the public-private interaction, we need to look at that also. Pattern of service delivery and the public participation in policy decisions. We discussed the other day, importance of all the stakeholders participating in making policy decisions. So going back in the history, there are historical evidence that earliest systems of medicine has been found in China and India. They had traditional systems of practices of medicines, systems of medicine practice in those countries, China and India, the Ayurveda and then the Chinese, the barefoot doctor and so forth, in the ancient times. And then with the Industrial Revolution, things came, people congregated into cities, then they needed healthcare. hospitals and things were put up, and industrial revolution had effect, and through that the need for healthcare and systems were needed, and further development occurred. And then Germany, the world wars, and then the politicization of workers in Germany. They were making various demands and so forth. And then in 1938, the UK national health system was established. That's why some of our systems are based on the UK national system. And there was a lot of reforms in India. There was a famous report called Bohr report in 1946, which where India followed that and made a lot of changes based on that. Then the famous Alma-Ata Declaration in 1978, all the countries in the UN system met in Alma-Ata, which was the capital of then Kazakhstan, part of the Soviet Russia. And they looked at this thing and they found that some people, basically the health is a basic human right, to getting services to look after your health, any human being. But they found that there's a lot of discrepancy. Some countries, some people were enjoying the best of health. They had access to good health care. Some countries, people cannot access to basic health care, so, but health is a basic human right. So why two ways? Not between countries, even within countries there were disparities. Some people enjoy the best of health care because they had the money, they can pay and get the health care. Some people could not achieve that. There's no. So then when they looked at, they saw this disparity, and they in 1978 they decided that they set up a goal by 2000 to achieve health for all. On that concept, to have everybody access to health care. So that was called the Alma-Ata Declaration in 1978, and then they set the goal health for all by the year 2000. Then they discussed how you can achieve that. So they came up with the declaration, which was the primary health care approach. So primary health care approach, which under several themes: equity, social justice, community participation, prevention and promotion, intersectoral collaboration, appropriate use of resources, and sustainability. These are the key things in introducing the primary health care system advocated in 1978. But Sri Lanka was practicing primary health care long before that. When was that Sri Lanka? In 1926, Sri Lanka established the first health center in Kaluza. Yeah, the community was provided with basic health care. The midwifery system was started. So that evolved. In Sri Lanka, we already had a primary health care system, although the world talked about it in 1978 as Alma-Ata. But anyway, we also had signed the agreement and adapted, and we strengthened our systems, and we had some achievements through that. So that's another landmark in the development of health systems. There was some restructuring in the primary levels, and this thing under this. Then in the 1980s, the issue of health economics was brought into healthcare. Right, the population was increasing, and then there were more demands, and then issues of efficiency and effectiveness. Then they had to do some structural program adjustment, health sector reforms, and then the World Bank was trying to dictate terms, and they were advocating countries, even Sri Lanka, do this, do that, this thing. And then in the 1990s, again, then they found that they were advocating various methods, but it came out that one size does not fit all. So you have to look at the country context. World Bank, although the World Bank says we could not, sometimes we had to implement because we had to get the money. and found that it was not working. Now the governments don't get dictated by the IMF or this thing. We stand on our say, this is what we want, you give the money, that is so. So one size does not fit all. Recognition of key elements of equity, empowerment and poverty reduction, so they were integrated into that. Standardization and improving performances, and then the area of evidence to improve systems, then the area of health systems research came into the picture. So those things happened in the 1980s and early 90s. And then the world, there's a report produced by the WHO every year, what is called the World Health Report. The 2003 report gives a lot of, discusses all the issues. It's an interesting book to read, World Health Report 2003, where they discuss about this primary health care and also about the MDGs. That was the time, in 2000, they started MDGs, the Millennium Development Goals. Okay, with that background, why we should study health systems? Why included in your training also, why should learn about health systems? It provides understanding or perspective to understand self. How are we doing our system, health system? You are working in the health system, you are part of the health system. We told the different parts of the health system. So, if you study these health systems, it will give you a better understanding how the dynamics in your organization or the systems works and the relationship with others. It helps to observe and examine strategies for achieving equity under different situations. So equity was a basic issue, treating everybody equally. And if you know the systems, then you can adjust the system so that everybody is fairly treated under the system. And also, if you understand the system well, then you can make generalizations. And you study the part of the system and then generalize. To create systems influence on health systems. So it's important that you can make influence your system to work harmoniously with the other systems and influence even the other system. What determines a health system? What are the factors that decides what a health system will be? What are the factors that will decide what is the health system that we have? Any idea? What determines the health system? What we have? Yes, the demand, the need that will receive. People are asking, then they have to provide that. This thing. So the demand for healthcare, what else? What are other things? Economy, whether we can afford. Also people want this thing, but we don't have money to provide that, then that will determine how our system should be received. Affordability and availability. Economic aspects. The economics will decide what sort of health system that they will have. And the other is the political. There are priorities, appropriateness, accessibility, equity, all those come into that. So there are economic determinants, there are political determinants, then we have the cultural determinants, acceptability, utilization, participation, community. So those will also determine the health system. Now what is happening now? People don't go to the next door hospital, small hospitals. They bypass all that and go to the biggest place. These are underutilized, the lower level facilities, and overutilization of the higher level facility. Everybody comes to the national hospital or to the there are utilization because acceptability. People don't go, they think that there are no drugs, not enough drugs there, and no specialists, so therefore they want the best of care. They go bypass and this thing, so that determines. Now they have realized that now unless all this time we were, so what have we been doing? We have been developing the all the big hospitals, all the modern technology is more and more people bypassing and going to the underutilizing. The small hospitals are used only less than 20%, 30% utilized. It's empty. And you have staff underutilized, so overworked or overutilization in the higher facilities. So cultural factors, acceptability, utilization, participation. So that also determines now the ministries under the World Bank Health Sector Project, they are going to restructure. Now they are focusing on the primary level facilities. They are going to improve those, train the doctors. They are going to provide community practice sort of system, and restructuring some reforms in districts, addressing these issues structurally. People like people want like now, like the family practitioner, people want doctors to talk to them now. So they are undergoing some training in family practice systems, and also going to implement some criteria, provide all the drugs. And in fact, this morning they launched what is called the ESP. It is called the Essential Services Package. Sri Lanka's Essential Health Services Package. And that have defined, okay, now that these are for that the World Bank is giving $200,000 for over 5 years to restructure and see that the primary level, they are functioning, people then start using them. So this comes from the determined, so that is the cultural acceptability, utilization with all this thing. They might put in the website, I will give you the link. Put it there. There are different forces asking for a change in the system. New emerging diseases. When AIDS came, we had to set up facilities, testing and treating patients. Earlier we didn't have facilities. Dengue was increasing. We had to have special dengue unit created in different parts of the country. So, new emerging diseases, we need to change the system. So, changing disease profile. Those days, most of the diseases were infectious diseases. Smallpox, cholera, hepatitis, diphtheria, and so forth. But we had to separate infectious diseases hospital separately to put people there. Now those have gone, most of the smallpox is eradicated. Diphtheria, about 5%, or polio, or diphtheria. There were separate wards, now they were all closed down now. And now, on top of that, now what is the change? The profile has changed. Earlier it was infectious diseases, now non-communicable diseases, which you need to treat lifetime. Right. So now the system has to change. The last several years we were using the same system to treat it. It didn't work. That's why drug shortages. I think that now they have realized that now they are addressing this change disease profile. Based on that, they have to change the systems. technical and diagnostic advance. So new technology is coming up and advances, so that also they are now raising funds for another special scanner. So new technology comes in, then you have to invest in this thing, then you need to change the system. You can't go on the traditional X-ray system. New technology has come, more cost effective and so forth, so you have to go for that. So you have to change the system. Now people are living more. Earlier 20, 30, 40 years life expectancy, now it has gone to 70, 80. Increasing further. So the disease patterns are changing, more diseases, older people get more sick, so their systems are also, then we need to have separate geriatric units, elderly care centers, facilities, geriatric clinics, right, and geriatricians. We had pediatricians, now time to come, we need, now they have just started the post-graduate program on geriatrics, because the need is there. Now next few years there will be a lot of people, so we need people specialized in treating those people. So longevity of life, we need to change our health system. New categories of caregivers have to come in. On top of that, the people are also expecting, they are more knowledgeable, the information technology has developed so much, people are well educated, people are well knowledgeable, and they demand more. So then we have to, not like those days, people like accept whatever is given. They want the red color, the different color water bottle, they give the bottle and they are happy. Now you can't do that, people know about the drugs and everything. So their expectations are also high. So that also we need to now change our systems. Subsidies and cross subsidies, right? So that's why we introduce some people who could not afford lenses. They were asked to buy the lenses, it cost 12,000, 18,000 param lenses. Some people could not afford that. So that's why government give a subsidy, and then the lenses are provided, sets are provided, and support them. Increasing non-planned expenditures. Sometimes on top of that there are disasters, which we are not ready to receive, but so your expenditure goes up, which you have not budgeted. So the more and more the droughts is coming, and I think the next month, May, June, we will start getting floods. And diseases and so forth, we will have to incur more and such. Then competing priorities. Different priorities are there, we need to address those. Improving awareness among people and rising cost of healthcare delivery. So these factors makes us to change our health system. You can't have a fixed health system. You can't boast of the system we had, and today it has to change because there are so many factors which affects. We need to change the system. You can't have a fixed system throughout. Time to time we have to change the systems. What do we, so those are the factors we learned about what determines a health system. Then we look at the other side, what do we expect from a health system? What are the goals of a health system? What is the main thing, main goal that we expect from a health system?
Increase quality.
Yeah, quality of care, improve the health of the people, right? Improving the health of the population, that is the main goal. Improve the health of the population. Responding to people's non-medical expectations. That's why people were going to the private sector. They prefer the private sector. Why? But they know that technically the government sector is providing better care, but they think, it was mainly the non-medical things. The clean environment, how you are received, and the sort of that we call the responsiveness. So responding to people non-medical expectations, that is called responsiveness. That is non-medical things, like cleanliness, how you are greeted when you arrive at a health facility, whether you are given a clean bed, clean environment, good toilet facilities. Those are not medical things, those are hotel facilities, right? So that's why people prefer to go to the private sector. Now the government institutions have started these funky improvement programs, the 5S and things. Now they are little by little we see that those things have come in there, but still the people have not changed their attitudes. We need to change that also. That also people expect to be, when they come to the facility, well received and talk to them nicely, that sort of thing. That is called the responsiveness, the dignity of the patient. So responding to the people's, that is another goal. Now they have realized, so the government facility, they are now going for the responsiveness also, not only the medical aspects, providing financial protection. That is another goal against cost of ill health. Some people go to poverty because of ill health. They have little money and then they become ill. They sometimes sell their property and spend for the this thing, and they go into poverty. They were just managing, but they can't manage because of illness, pushing them into. So therefore, there must be mechanisms to protect them. If they get an illness, they don't go into poverty. So that is financial protection against the cost of ill health. That is called catastrophic spending. That means people are pushed into poverty because unexpected expenditure comes in because of sickness they don't expect. They get a cancer or something and cost a lot of this thing. So that is called financial protection. So how to protect them financially, not making them go into poverty. So those are the basic goals, 3 basic goals: improving the health of the people, responding to the people's medical, non-medical expectations, and financial protection, protecting them from going into poverty. So then what are the issues that we have in the national health systems? Generalizations of performance and trends. Over the years we need to look at trends, and then you can't generalize the performance. We have performed well in certain areas, but certain areas are lagging there. Now, one example is we have reduced the maternal mortality, infant mortality, all that, but our nutrition indicators have not kept in like that. It's not improving the way the other indicators improve. So you cannot generalize the performance. Political dimensions, dynamism, political aspects of it. The politicians have successive governments don't touch the issue, although they know that we need to generate more money for health. They will not introduce a user fee. So government will do that because people are also used to the free healthcare system. So various forces deciding the character of the health system, right? Which affects the different forces. Now, if you make a change in one in part of the system, it affects the other parts of the system. Say, if you one part, say staff, health worker number, if that is reduced, that will affect all the other services or the parts of the system. Right. If you introduce some new technology, it will affect, you need to train people to use that technology. So it affects the other staff development, introducing. So various forces deciding the character. Impact on health. There is how does the health system make the impacts on this thing, and relevance to human rights. Right? So health is considered as the basic human right. So now let's look at what are the components of a health system. resource production, resource generation. What are the resources, basic resources we have? We need to produce human resources. Health system cannot function without human resources. So we need to, the health system part of that is generating these resources, finances, equipment, drugs, producing drugs. Then get things organized. Program organization. Priority areas, so you have different programs for maternal and child health, for various control programs. So you need to organize those for the priority areas, program organization. Then economical support. There must be mechanisms in the health system to provide economical support. Then running the services, management, and finally the service delivery. So these are the components. We learn 4 basic functions: resource generation, then service delivery, like that. So these are the basic 5 components of a health system. Then how are we going to classify health systems? Some are classified according to the service delivery. Depending on the type of services, we classify the health system according to the service delivery. We classify health system according to the nature of the service. Okay, whether you have to pay for that thing, not or right, if it is paid, you classify public-private. Because that is, service is, the nature of service is that you have to pay and get the service. Other one, so they are public-private. And then we classify according to the doctrine. What are the classifications? We classify our health system according to the system of medicine practice. We have the Western system of medicine. We have the traditional system of medicine. Again, traditional, we have the Ayurveda, Unani. So, by the type of system that is practiced, doctrine, we can classify the health system. Traditional medicine, it's one system. So health systems can be classified according to these things. Based on the service delivery. First one was based on service delivery. Here you can classify into public sector, private sector. Service delivery. This is the public sector hierarchy, how it is organized. Then the private sector. There are private corporate listing, and then other NGOs, and also they are also private. They are non-profit, these are all profit. Basic, so it depends on the, again in the private sector we have hospital, we have corporate hospital, we have nursing homes, we have people doing medical insurance. Then there are other NGOs and things like that. So based on the service delivery, we can divide the health system into public and private. That is one basic classification. Then based on the doctrine, the public sector, we have the Ayurveda, the allopathic system, that is the majority of the practice people in the government sector is practicing the allopathic or the Western system of medicine. And then we have the indigenous systems of medicine, the traditional system of medicine, also practiced, that is based on the doctrine. Earlier public-private, now here, depending on the type of medicine that is practiced, we can divide the health systems. So the allopathic, the Western system which we are more familiar is a systematic, strong database, pharmacopoeia, there's a pharmacopoeia, there's diagnostic support, it is quick, international procedures are there, epidemiological developments, cost aspects, isolated approach, dependence on technology, human touch is missing. That's the issue that we have. Hereditary diseases, sometimes you find the drugs themselves causing diseases, or hospitals having hospital-acquired infections and so forth. Sometimes eating a lot of resources, irrational drug use. So those are the issues that we come across in the Western system of medicine. In the traditional systems, we have the alternative systems, or indigenous or unofficial systems of medicine. Acceptability, that important feature was in the village area. They respect the healers, and they reach the masses, the rural base, renaissance, and the role in the present system. Right. So when you look at the types of health systems in relation to traditional medicine, you have there are exclusive, like UK or Germany, inclusive systems like India, Pakistan, where we have both the Western as well as the traditional systems of medicine is practiced hand in hand. Bangladesh, Thailand, China, Nepal, they have integrated. In one facility, they provide both. Right, that is integrated. Inclusive, exclusive. They stick to only one type of practice, the health system. And we still ponder over health system. We are still struggling about we don't still understand, not well understood, large enough in context and content and context. A system which needs inputs and aim to bring out outputs and outcomes. Now next, let us look at our health system, and then we'll look at the other countries. So, what do you know about our current health system in Sri Lanka? We look at the historical developments, health status issues, and then the policy strategies and the healthcare services. When you think that our health system, we can trace the history, 100 years, 200 years, 300.
To ancient times.
Ancient times, is there evidence? How can you say that there had been what is the evidence to say that we had 1,000 years ago, we had a health system?
Ruins of hospitals.
Yeah, there are ruins of this thing, and there have been in the documentation about the kings appointing various, right? So they say indigenous medicines has been practiced, system of medicine practiced more than 2,500 years in Sri Lanka. Ayurveda has come from India in 300 BC, and the allopathic medicine came with the foreign invasions. 1505, the Portuguese came. With that, they brought in some. So we have got that, but it's still in the ancient. They say in the history, the 500, the king Pandukavaya, 4th century BC, he has appointed the PHIs. They are called Chandalas, persons of low caste appointed to work in cleaning the streets, and 200 Chandalas for clearing the sewers. They were worried about the environmental sanitation. And so sanitation and matters related to public safety were entrusted to an officer called Nagara Guttika. What the currently PHI make sure the environment is clean, so that time the king has appointed Nagara Guttika to see that the city is clean. Then there are remains of various ruins of this thing. These are some of those ancient things. These are ancient hospitals. Those some are the sewage systems are very advanced at that time. This is the first health unit, primary health care started in Sri Lanka in close to the Paluganga road there. The building is still there. Parakota, the first health unit in South Asia. There was the midwifery services were provided, maternal and child care provided. So then in Mihintale, you have been to Mihintale, have you seen the, you have climbed the thing but not seen the, at the bottom of the rock you have the hospital. Well, they say that is the world oldest hospital where you can see the evidence. Then various with the infectious diseases, malaria, filariasis, TB, various campaigns were set up time to time from 1922, the malaria, filariasis 47, TB 52, like that. So those system has developed for specific diseases, things have been created, structures have been created. And then a lot of changes happened after the universal Ladar Panchayat, people were allowed to vote in 1931. That had impact on the health also, they decided, and in 1944 they provided free education system, and the free health services has been provided since 1930s. So now we see the results of those investments. Life expectancy has increased compared to other countries. India, Myanmar, we are ahead. And they say people have access to a health anywhere in the country. Within 3 kilometers you can get to a health facility, some form of health facility. So that is the network of all the health facilities. You can see well spread out to that's one of the plus factors that we have. These are the teaching, general and basic hospitals, big hospitals. Again, a good coverage is there. So historical developments, 1950 they started to decentralize. 53 they appointed superintendent of health services, the current RDHSs. 15 areas were carved out, and earlier before that it was run by from the central ministry. After that the services evolved, and then the next landmark is the 13th Amendment, 1987. Provincial councils were given to run mainly the preventive services and the small hospitals, right? So those reforms came in the 80s. So time to time things have changed, and so the mission goals out there is the strategic objectives. So these are the the different sectors that they provide. We have the government sector, the private sector. In the government sector, there are which is providing Western medicine or allopathic system of medicine. Also in the government sector, we have the indigenous system, the Ayurveda department and the Ayurveda hospital run by the government. So indigenous run by the government. Government don't provide other systems of medicine, but in the private sector you have again the Western practitioners, Western practices hospitals. Then we have the private Ayurvedic practitioners, private Ayurveda hospitals, and then there's a whole heap of other practitioners, even the quacks, they are also providing healthcare in the country. Right. So this is a very basic classification of the health system in Sri Lanka. So it's a multi-sectoral thing, different types of medicine practiced by different sectors. Right. So remember this diagram. Right, then you know the hierarchy, the Ministry of Health and Department. There is no two separate entities. Now they are both merged together after the 1961 white paper. That said, it cannot function separately, so the Ministry and the Department are together. And then after 87, the provinces were given the mandate. They are running the provincial health services. There is a provincial Minister of Health, there is a provincial director of health, right? They have what is called the provincial ministry of health, and then what is the next level? Then they under the provincial ministry there is a provincial department of health and the provincial director of health who is head of the department. Then we have deputy provincial directors of health. They are now designated as regional directors of health, RDHSs. That is, they are in charge of a district. Then at the divisional level, now this has been given up. So in the Western sector, we can divide into the preventive health, broadly divide into two systems: preventive health services and the curative health services. And in the curative, we have the hierarchy with the national hospital. Then comes what? Yeah, the teaching hospitals. Then the general hospitals. Now, this was the earlier classification. Now, this has been changed. Right? This was the early classification before 2003. This was the classification. There were 13 types of institutions. In 2003, what we have done was that in terms of change this into all in line with the administrative structure. Well, the highest administrative structure is the provincial. So for the country, whole country, we have what is called the national hospital. So that is the only one in there. And then teaching hospitals. Ideally, each province should have a teaching hospital, which is not. Some provinces don't have a teaching hospital. So it is injustice. So we are treating differently. Now some people in some provinces get all services, specialists in all specialties in the teaching hospital. People in some provinces don't have, they have to go to the other province. So to overcome that, what they have decided was that teaching hospitals, the next level, the general hospitals in provinces where there is no teaching hospital were improved. So they were called provincial general hospitals, and they are providing the same services which a teaching hospital provides. Now, Ratnapura is such a hospital. There's no teaching, now it will become a teaching hospital with the Sabaragapo campus opening up. So, Vadul, there was no medical school. It's a general hospital, but they improved the services now. So each province has the principle is all the provinces have a teaching hospital or a provincial hospital providing the same services. Only difference is that there is no teaching hospital because there is no medical school. So that was one change that was made. Each province will have the services similar to a teaching hospital, but no teaching. Then the next level was the base hospital, which is again a misnomer. The main base hospital is also wrong. Do you know how the word base hospital is? It was the hospital, they built the British Armed Forces. People set up hospital where they had base camps. So they wanted to treat their soldiers, so they set up, so those were called base hospitals. It is really serving a district. Province, these two provinces, this one, each district has 2 or 3 base hospitals. You take Gampaha district, there is Gampaha, Negombo, Watupituela, Avi Watupituela, Avisala. This is the 4 base hospital, the Watupituela, Avisala, and Negombo. Kalutara district, there is Managura, Kodana, 2 base hospitals. Similarly, each district has 2 or 3. So what they decided was, each district should have 1 good hospital. So they elevated the status of the base hospital and called it, out of the 2 or 3 base hospitals, they selected 1 which is more central, more developed, and they renamed it as the District General Hospital. Now each district has 1 District General Hospital which has all the specialties. Earlier there was only 1 surgeon. They had now 2 surgeons, 2 first physicians like that. They increased because otherwise if the person goes on leave, nobody. So those were called District General Hospitals, multiple units. So they were improved further, and we have now Hambantota is one such hospital, District General Hospital. Now most of the services are there. Like the remaining base hospital, they are also serving a district. They were named District Base Hospital, continue to run the same way. Now Horana is a District Base Hospital. It continues Horana in the Kalutara district. Kalutara General Hospital is the District General Hospital. Then the next level, again a misnomer. These district hospitals were not serving a district, they were small hospitals. 2-3 wards, 100-150 beds, 1 medical officer, 2 medical officers, no specialists. That was the earlier district hospitals. So peripheral units are still smaller, about 50 to 60 beds, 2 wards, 1 bed MOIC, and rural hospitals also same, 1 or 2 wards, about 20-30 beds. These are really serving this is the provincial level, this is the district level. What comes next? What is the administrative level? Province, district. What is the next administrative level? You have the province, then you have the district. What is the next administrative level? Division. We have divisional secretaries. It's about 80,000 population. So these are serving that one AGA division or divisional secretary, about 60-80,000. They were in different sizes, but they were put together and they were called divisional hospital. Because it goes in the terminal. Divisional secretary, divisional hospital. Right? Because they are different, initially they have said divisional hospital category A, category B, category C, small ones are called category C to distinguish. After some time, all will be same. Even here, the district general hospitals were categorized. Some were very much developed, some were not well developed. So they said district general hospital type A, type B. So that's a temporary resolution. So we have national hospital, teaching hospital, provincial general hospital, district general hospital, district base hospital. These all 3 were called divisional hospital. Now even the boards carry, you don't see these names now. When you go around, you say divisional hospital Kandahar. So they are called divisional hospital. This is the old nomenclature. They don't have specialists. The difference is divisional hospital is a great medical office. And then these were also renamed. Earlier these were manned by the AMPs, assistant medical officers. Now we don't train and we have now appointed MBBS doctors to these places. These were only running OPD. What's the purpose having a doctor and only running a OPD? He can't suture a wound, he can't attend to an emergency with those facilities. So the name and the functions were changed of these 2. They are now called primary medical care units, PMCI, primary medical care institutions, PMCIs, primary medical care institutions. So there's an MBBS doctor, they provide emergency care also. And then in addition to that we have special hospitals. What are the special hospitals? We have the cancer hospital, we have the maternity hospitals, Carson Street, EMH like that. There's the FEBA hospital, mental hospital. There are about 13 or 14 such hospitals. They don't fall into these categories, they are called special hospitals. Right, so that is the structure of our curative health system. So then these are the figures. There were a number of institutions, these have changed, I think these 2005 figures. So this is the structure overall. See, you have the central ministry, then you have the provincial ministries. Under the provincial ministry, there is a regional director of health services. Under that, we have the small institutions come under that. The divisional hospitals and the base hospitals come under the regional district because they are at the district level, below the district level. And then the preventive services run by the medical officer of health. And under the medical officer, there's a team of health workers, the PHI, PHM, and the other staff. And then through the vertical programs, they have at the regional level MONCH, regional epidemiologist, MONCD, regional medical officer. And then for the vertical programs. At the district level, they have staff for them. Right. So this is the basic structure. Now there are the name given divisional director was temporarily it was removed. We have gone back to the old name of medical officer of health. And then these are the services, preventive health services, maternal and child health program. We provide all this through the MOH system, school health program, environmental sanitation, health education. Then there are various specialized campaigns and bureaus, health education bureau, health now that is called health promotion bureau, family health bureau, anti-malaria campaign, filariasis campaign, STD campaign, rabies, leprosy. So priority diseases, there we have campaign, various control programs or campaigns. So the MCH programs continue care for the mothers at different stages, pregnancy, pre-pregnancy care, then antenatal care in the hospitals. So there is an initiative called Safe Motherhood Initiative. Life its approach is distinct. So there are teams now being to further reduce the maternal mortality, and I think there are emergency obstetric teams, neonatal teams established at different parts of the country to ensure a safe motherhood. And then also postpartum care provided in the hospital as well as in the community by the midwives. So there are so many caregivers to improve the mother's health in Sri Lanka. Then various vaccine preventable diseases were introduced, vaccines were introduced from time to time, and immunization, various landmarks, achievements. So in the private sector we have the Western system, indigenous and other, and the Western system there are now about 220 private hospitals and over 800 general practitioners. It is rapidly expanding. And various services. Then we have the indigenous system of medicine, both in the government as well as in the private sector. Right? So that is the overall health. Very briefly the health system. You have got an idea. You know what. Now let's look at some other countries. You have your presentation.
So I mailed one presentation to you.
Oh, no, I can't remember. Doesn't matter. Quickly go through the different systems and then compare them. Overview of healthcare systems around the world. So I have selected 5-6 countries. We define what a health system is. The health system is the sum total of all the organizations, institutions and resources whose primary purpose is to improve health. Basic definition we know. A health system needs staff, funding, information, supplies, transport, communication, and overall guidance and direction. And it needs to provide services that are responsive, and financially fair while treating people decently. A good health system improves people's lives tangibly every day. So those are what he's saying is about the 6 building blocks and the broad goals that what we expect as goals are: responsiveness and financially fairness, and treating patients decently. So let me quickly discuss. We already you presented the US and the Japanese, the first and the last one. Let me tell you briefly about the few other countries which have some different systems of health systems. Now, one is to consider how you categorize what system it belongs to. You can go by the definition or the categories. That is how we choose to define the countries as a health system. And what umbrella terms do we use to describe this country's healthcare system? One is the definition you use, how you define what a health system is. Secondly, description. What does this country health system entail? What about the system? What type of system? And then thirdly, benefits and challenges. What are some of the advantages and disadvantages of each of these countries' forms of healthcare? So our comparison is based on these 3 areas. As she discussed, the US system. Now, the 3 areas, the definition. Now, you mentioned that it is a privately funded healthcare system. Right? Ours, in our country, what do you see? Is it that or different? Different. Ours is basically more publicly funded, but it's a mix. Right? We have some private also. So in the US system, that is the only developed country that does not provide universal health care. So the universal care, everybody is provided care. There they don't know. You showed some figures, 14%, 12% people don't get any form of care, no insurance, and they don't get care also. So although it's a developed country, in that sense, they are not providing universal health care. Everybody having access to care. Some public funding is provided. From where does the public funding comes? The 2 insurance system for the poor people. They have this Medicaid and the Medicare system. That is, the government allocates some funding. That's the only money that other things are privately funded. Private insurance systems. So that is the description of the US system. Only that they don't provide. You can't say that they are providing universal health care because everybody is not covered. Some public funding, partly funded public, although it's privately funded. Some parts are there. This unique Medicaid and the Medicare system. Then the citizens are required to obtain healthcare coverage from independent insurance companies, so pay for healthcare coverage at their own expense. So there's no option. They have to either get insurance, private insurance, which are very costly, or they have to directly pay and get the services. From your figures also, it is 1 in 6 Americans are uninsured. There are about 14%. So were not insured. Some states more than that. 1 in 6 Americans are uninsured. They don't have an insurance coverage. Initiation of Obamacare in 2012, which regulates health insurance and not health care. It was mainly to regulate his policies were to regulate the insurance. Right. So what are the benefits of the US, this privately funded healthcare system? Healthcare that is provided is quite good. That's one point that people acknowledge, that their services are, the quality of care is good. and they have, because they have the state-of-the-art resources. They have a rich country, they have resources, so their services are good quality, but it's very costly. So what are the challenges for the US system? Firstly, limited government involvement in conjunction with lack of consensus. So very little government control, because only the Medicaid and Medicare provided, other things are all private. Compared to us, most states, the government is running. Costly for uninsured and low-income individuals. Costly because if they are uninsured, they have to pay. It's very costly there. The services are very costly. And for the low-income individuals. Not everyone can obtain healthcare coverage. So that's why some people can't get, some people die, they don't get healthcare. Controlling of healthcare spending. There's some controlling of healthcare spending through this insurance systems. Those are the challenges. So basically, you have now got a some idea about the US system. Then what is the UK system? Anybody knows about the UK system? What sort of contrast to that compare with our Sri Lankan one? Now, health systems, there are, last time I think I told you, the health systems, we can group them into 4 broad categories based on what? If you look at the health system, this is provision of service, public, private. This is funding, public, private. Right. This axis you have public provision. Services are provided. In Sri Lanka also services are provided by both public and private. Then, who provides funds for this public service? Government. Okay, so this box is the government services, right? Why? Publicly funded, publicly provided. Government provides the money, government provides the services. Our system is that our government health services system is a publicly funded, publicly provided service. Clear? Right. Then, what is this box? Right. Privately funded, privately provided. Now, who provides the private services in Sri Lanka? Private healthcare? The private, the GPs and the hospital, private hospitals. Right? Who provides the funds? From where does the funds come? Do the government give the money? No. So it doesn't come in under the government is not providing money to provide the healthcare in the private sector. So it is privately funded, privately provided. This one. So our private sector falls in this. It's an example of this sort of health system. Privately funded, privately provided. Then there are other combinations. Can you think of publicly funded, privately provided service? Money comes from the government, service is delivered by private. Any example? Yeah, EPF is the contribution. It's not, we need to look at the services delivered And from where does the money comes to provide services? Now, is there an example where the services are provided by the private sector, but the government gives the money? In Sri Lanka, can you think of an example? You can't have a case. See, there are instances where that happened. Insurance people don't provide services. So private, the funding comes from government, but the services are delivered by private sector. Or the other way, this is publicly, yes. Funds are provided by the private sector, and the services are delivered by the public sector. That's another. Give me an example for that also. There are examples, situations in our health system where this happens. The money comes from the private sector, the government is providing the services. Yeah? Yeah?
Patients has to buy the stent and all from
Right.
private sector and the government sector.
Government provides the services. Okay. That's it. You see. Right.
So President's Fund, sir, it provides funds from
Funds?
government to
Right. That's a good example for this one. Government provides the funds, the people get the services by the private sector. Because there's a long waiting list. Government poor people, they can't wait, they will die. So the President Fund gives money, okay, you can go and get it done privately. Bill is paid by the government. So privately funded, publicly funded, privately provided. That's a good example for that. So can you think of privately funded and publicly provided? Paying what? See, in government hospitals, very little. Right? You can take even Jayawardhanapura. People pay, not the government. But the services are provided by the government. Money comes up, people pay. So they are doing now after hours also, surgery also, they have list and channeling, all that happens in Jayawardhanapura. Money comes first, but services are provided by the government hospital. Right. So these are the health systems can be divided accordingly. You can look at the health system, who provides the funds, who provides the services. There are different combinations. So different health systems have different combinations of these. Now US health system, where does it, which box you will put the US health system in this? Where will you put the US health system, with which box? Which box you will put there? Or where does the money come? Who provides the services? Majority. She said it's private insurance. So from where does the money come? Private. People pay money and get the insurance premium, then get the private insurance. The government doesn't pay. It's only for the few people, Medicare, Medicaid, that comes from the government. It's very small percentage. Majority of them, it's a privately funded. Who provides the services? Private. So US, mostly this box. US is mostly this box. Sri Lanka, mostly this box. 90% of the inpatient care is provided by the public hospitals. But outpatient department, it's a little different story. Private sector, 50% provided by the private sector also. So Sri Lanka falls mostly into this box. Right? So you can analyze any health system in the world, remember this diagram. Provision, funding. And then you can discuss a health system. So, USA system you can discuss based on this. It falls into that category. Privately funded, privately owned. UK, where will you put? Anybody knows about the UK system? Who provides the UK? What is the unique thing there? NHS. You heard the word NHS, National Health Service. It's like Sri Lanka. It really got from the British system. It's a publicly provided, publicly funded service. So it's somewhat closer to Sri Lankan system, publicly funded. And they also have universal healthcare coverage. Everybody is covered, publicly funded, publicly. So, universal healthcare. Description: healthcare is covered by the National Health Service. So everybody is covered under that. That's why they call it universal healthcare. Everybody covered. Free at the point of use for anyone who is a resident in the UK, like us. We can go to. Like that they are receiving, but the government funding of NHS is provided to. How does the government get the money? They tax, like us, they tax and treasury gets the money. From that money you provide services. So everybody pay taxes, not direct taxes. Most of the people are paying indirect taxes. When they buy a toothpaste tube, you pay few cents as taxes. Your brothers collect that and pay the treasury taxes, and that money is given to. So we also pay for the health system, although we think we are getting it free. Our money they collect by taxes, and then, so that's a good system. Healthcare is covered by the National Health Service, free at the point of use for anyone who is a resident in the UK. Funding of NHS is provided through taxation. So Sri Lanka is also somewhat similar. What are the benefits? Employs a large number of healthcare workers. Like us, we also have about 140,000 people working in the health system in Sri Lanka, in the public health system. Limited costs for residents. People don't have to pay much money. Good standards of healthcare. Wide ranges of services offered under coverage. So a lot of, even now, stents and bypass surgery also done without any payment. Right? Challenges. Firstly, Sri Lanka also faces like this: high healthcare running costs. Now, day by day, the costs are going up. Every year, budget goes up, health budget goes up. Long wait list times coupled with extensive patient demands. In UK, this is a big problem. There are long waiting lists. And strain of resources. Right. So UK system somewhat closer to our system, right? Then France. Anybody knows about the French health system? France also universal healthcare, provision of universal healthcare with a mix of private and public hospital and ambulatory. They have a mix, like somewhat like also. They have both the public and the private inpatient as outpatient. Solo based fee for service private practice for ambulatory care. There's like GPs, they have GP system. Public hospitals for acute institutional care, for emergency care. Anybody can walk in and get the services, like our country. All covered by National Health Insurance. They have an insurance system, what called NHI, National or reimbursement. 90% of the population requires additional insurance to cover costs that are not covered by the National Health Insurance defined. These are the things that benefits that you get from the insurance. Other thing, so the people, what they do is, even in Sri Lanka, sometimes they are covered by this thing, but they would take a private insurance also, selling for insurance, and they get by, some people have that also. They are covered under Agrahara, but Agrahara have certain limitation, they cover only, government employees are covered under the government insurance system. So the difference in France is that they have the public national health insurance, but some people on top of that have a private insurance system also. Sri Lanka, it's very minimal, with very little, about 1% to 2% private health insurance coverage. But in France, there's a much more private insurance also than on top of the government insurance, NHI. So what are the benefits? High in health status and overall satisfaction. So people are okay, like in Sri Lanka, they get the services. Ranked number one by WHO in 2000. No gatekeepers regulating people to specialists and hospitals. There's no monitoring system as such there. Largest proprietary hospital sector in Europe. They have a good hospital system. Challenges, decision making is highly centralized. All decisions are made at the central level. Disparities in geographic distribution of resources. Uneven quality in the distribution of health resources. High healthcare expenditures. So similar to us, we are also facing the similar challenges. Right. So France also somewhat similar to ours, little different. They have a more private sector also. Australia, any idea? Again, universal health care, that means everybody is covered. It's a mixture of Commonwealth or state funded services in conjunction with private service to provide universal health. But with Sri Lanka, they also have both the public and the private mix. The state funded services and also private services to provide. Medicare is the Commonwealth government's universal health insurance scheme. They have an insurance scheme. Government take only the Commonwealth thing, government universal health insurance scheme. Medicare provides treatment at any public funded facility and subsidies funding for service outside this scope. For certain services, they give the package, people are insured, they have to pay the premium and get the insurance, and they are, but certain limited facilities are provided. And Medicare is funded through taxpayers' dollars, so from the tax only, Treasury pays the insurance. Citizens encouraged to obtain additional healthcare coverage. So that's different there, because the government coverage only limited cover, the other people had to go for some private insurance to get the other things covered. Benefits: low income earners may qualify for health care without paying the required tax. So they have for poor people special this thing. Good quality of health care. Again, Australia have a good system of health care. Challenges: there are limitations to Medicare and users can still incur costs. So there are limitations. Medicare don't cover everything. And they also have shortages of nurses and doctors. That's why Sri Lanka is going there. Canada. Anybody knows that? Canada also similarly universal health care. It is again publicly funded, socialized universal health care. Federal government provides the framework for the provincial governments to administer health care via the Canada Health Act. Like in Sri Lanka, the provincial provide the central government lay down the criteria and the provinces have to provide the services. Healthcare control is highly decentralized. Provinces are providing the services. People are covered for healthcare under their own province or territory. They are covered in their province. Each province territory determines what is covered under healthcare in addition to the basic coverage outside. So each province can decide how much what they will cover. So there are differences, not like in our country. Benefits: healthcare coverage is inclusive of all people. So they cover everybody. That is why it is called universal healthcare. Excellent standard of healthcare. Canada also have good quality care. Funding is allocated according to healthcare and is separate from health administration funding. They have a funding separately for administration and for provision of services. Challenges, tension between federal involvement in healthcare because the provinces have their own say, they can do whatever they want, but the federal government also have some controls. Healthcare is not uniform for everyone. So the provinces have their own way of providing their decisions. Private healthcare emergence. The private sector is also developing there. Shortage of doctors and nurses and growing healthcare costs. Very good. Paturega. Then finally Japan. What was that? Where will you put in the boxes?
Yeah, it's generated by private sector.
Private.
Even stuff funding is also private sector.
Yeah, privately provided. So they have a public, the public health insurance system. Is that so? The government covers the population. They had to obtain, the people have to obtain the government insurance system. Healthcare plan encompasses all essential services with the exception of some dental and corrective vision treatment. So dental and eye care, other than that, other things are all covered in Japan by the public health insurance system. All enrollees have to pay a co-payment. That is the difference. They have to, it's not totally government. They also have to put in some, that is called a co-payment of 30% on all goods and services with the exception of elderly, young children and low income individuals. So they have accepted that. Other people have to, I think Sri Lanka also might have to go for these people. For the poor people, you accept them, for the old and the young. But other people, why we see sometimes the people driving the BMW come and get the operation done free of care from the National Hospital. And so they can pay for the services they are running. So that is important. So all enrollees have to pay a co-payment. Sometimes we may also might be able to introduce something like that to exempt. That's how I think Javadharpura does. They bring the grammar Nilari certificate. This thing they accept from certain payments. Other people have to pay. They don't produce this thing that they are low income. All financing is publicly done in conjunction with job-based insurance premiums. So it's public funding. Some avenues of privatized healthcare exist but are limited to specialized services such as dental. So dental, eye care, lot of things, because those are not covered, so private people are providing those services. Payments of private care services are determined by complex national fee for service. They call it fee for service, and they have charts which gives for if you do a appendicectomy, this is the amount that's what Sri Lanka also they are going to introduce. They want to fix the private sector to, they can't charge more than that. But otherwise they have to go to different hospitals, these different charges are given. So payment fee for services and no gatekeepers, no control there. Benefits achieves good medical outcomes, so their results are good quality care. In comparison to other countries like USA, the cost of the system is low. Like US, the costs are very high. Large number of hospitals and beds per capita. They have seen even the elderly care homes. For the next 10 years, they have now beds, they have facilities. Hospitals also like that because the elderly are increasing, and they are planned to taking care of them. Challenges, large demand on the healthcare system due to aging population. That's what we are also now facing. Large demand because old people become sick more often, so you have to provide more care. People seeing the doctor too frequently. It's Sri Lanka average 5.5 visits per person per year. Average, every person in Sri Lanka, average on an average visits, that's the average. Some people go more, some people less. 5 visits to a doctor. People seeing the doctor too frequently. Strain on public financing, considered not so sustainable. Patients treated too equally. Shortage of specialized healthcare workers. So those are the challenges Japan has. Right. Okay. Any questions? So I hope you got an idea about different systems in the world, and you can remember that, and you can classify now what we learn what a health system is, and then how what are the different how we classify systems based on the funding, like public, private, based on the type of you can classify based on the type of system of medicine practice, traditional or Western or indigenous systems. Or we can classify using this public, private funding and provision of services, how you then according to that you can classify. So the health systems can be classified. You can look at any health system in the world. These cover the different systems into the research. Healthcare directly through the government, that is public, that first box. Publicly funded health insurance with comprehensive coverage. So then traditional sickness insurance, fundamentally a private insurance market approach. Germany is an example of that. They also have a private insurance system. People have to pay and get the private insurance, and they are covered through that. Then we have national health insurance, like in Canada, Finland, Norway, Spain, Sweden, most of the European countries have a national health insurance, even UK. National health services, like these are the service angle, that is the insurance, national health services. UK is the example we took. Denmark also similar, Greece, Italy, New Zealand, Portugal. National Health Service. Then we have mixed systems containing elements of both. Insurance, sickness insurance as well as coverage. Now, Switzerland, United States, it's a mixture of those both. Some countries differently, when you compare with the US, they compare here different. US is the country which is spending a lot of money now. Your slide showed about 4,000. Now it has gone up to about 5,000 per capita expenditure. United States for health. We spend only a few hundred dollars. UK to 2,160. US 5,000, double that. Germany, I think I just German healthcare system is based on the programs they call they have what you call the Bismarck model. This word also you might come across when you are discussing health systems. Germany has this Bismarck model where they have a insurance system. They have basic approach of mandatory enrollment to autonomous sickness funds financed by payroll taxes lies at the heart of German social. They have a social insurance program that is called the Bismarck system. So German is a little different from the other systems. Okay, we'll stop there. I will email the presentations. What I couldn't do because May lectures have been cancelled because of the low attendance. So what I couldn't cover is the international agencies. I will send the presentation about the WHO, Red Cross and all that. Not much. Then about, did you get your assignments?
Yes.
Yes, so you had to do assignment. I think you had to identify a problem and develop a proposal or something like that. No?
And I think comparison of the systems also.
Right, yes. Okay.